Hi everyone, welcome back to the Dr. Sia channel and to the series that I call 10 most common mistakes that ISTDP practitioners make. And in this video, which is the second video in the series, we're going to be talking about assuming task agreement when there might not be an agreement at all on what the task of therapy is. Let's get started. All right, so in the video here, what am I saying? Sorry, I went back to the start again. Okay, so let's talk about overlooking task agreement. Now, what I mean by overlooking task agreement is I myself, when I first was an ISTDP therapist, sort of starting out, often I would make an assumption that when the person comes to therapy, that anything that deviates from the psychotherapeutic process is a defense. Now, that could be true. There could be someone who actually knows what therapy is, and everything that they do is delineation, or if you will, is a way to thwart our efforts to have a psychotherapeutic focus. And that was very much the belief of Davanlu, and I believe that that is not the case. I believe that there are a lot of people who... Actually, wait a second. What am I saying? That wasn't a belief of Devlin at all. I made it. Sorry to misquote. Sorry to misquote. That's not actually true. Anyway, back to the idea. So a lot of people will come to therapy and they will not really know what the task of psychotherapy is. So you can't just kind of assume that everything that the person says is a defense. Defenses will appear, and there will be plenty of defenses that appear in therapy. But before the defenses of therapy, you have to look for the barriers of a psychotherapeutic relationship. If you don't deal with the barriers of a psychotherapeutic relationship, then there's no point in looking at defenses because you're not doing psychotherapy. If there's a barrier to psychotherapy, you are not doing psychotherapy, and anything that you look at in terms of defenses will be useless because, one, you don't have the permission of your patient to look at their defenses yet. Two, you don't have a task, a bond, a goal on what you're even trying to achieve with each other, so there's no point in looking at defenses yet. And then finally, three, you're going to piss your patient off and they're probably going to leave, and then they're going to go and tell some other practitioner how terrible ISTDP is because the therapists were just sitting there going, you're defending, you're defending, you're defending. So don't do that. Instead, you have to look for and make sure that there is an agreement on what the task of therapy is. Why you're sitting here together, what you're going to do together, and how you are going to achieve that together. Now, a person might come in and might have a very clear goal, and they might not be projecting so that they might be able to bond to you, but they might not agree that the idea of health benefit for them, that their well-being will be achieved by overcoming their defenses, by getting in touch with their emotions, by reaching through their resistances. They might not agree on that idea. So that's something that you have to check. And you can check that very early on in therapy. Even before you start doing therapy, you can ask them things like, do you know what ISTDP is? Have you ever heard of ISTDP therapy? Have you ever done any therapy before? Have you heard anything at all about the therapy that we do here? Just imagine. And I know that therapy is a lot about defenses, and I know that, and I consider myself to be a quite okay ISTDP therapist. But I always check to see that my clients, my patients, actually know what therapy is and that they're there for the right purpose. For example, I'll give you an example if you think that that doesn't sort of, if that might not be important. For example, I asked the patient, as I always do, before we kind of start, as we're checking confidentiality and working on the video and that, I sort of say, now, have you ever heard of ISTDP therapy before? No. Have you ever heard of therapy before? No. Do you know why you're here? Well, my doctor said I should come here. Okay, well, do you often go to places where people tell you to go? Yes. So there I was checking for a defense. And I go, well, why are you here? I don't know. I was just I come here because I was thinking that maybe you have medication. Doctor says that I'm depressed. And they're thinking that, maybe you have medication for me. And I said, well, I don't do medication because I'm a psychologist. I do psychotherapy. And he was saying, oh, but I want medication. Okay. And so do you want to do psychotherapy? No, I don't even know what it is. I explained to him what it is. And he said, oh, I don't want to do that. I don't believe in that. I have a imam and I go to my imam to do kind of my spiritual stuff. I said, okay, so what is it that you want to do here with me? Nothing. I just want medication and then I want to go back to my imam. Okay, well, thank you very much. I'll see you later. I gave him a referral to a psychiatrist. He went and saw a psychiatrist and he did his healing together with his imam. So you have to kind of realize that there are other reasons that people might come to therapy, and there are other barriers that may be coming to therapy other than just defenses. If you assume that there's an agreement on a task there, imagine if with this person I start kind of looking at their defenses and whatnot, and they might even go down that compliant road with me. And sure, there are some tendencies here, and sure, we saw some tendencies for this person to be compliant. But hey, look, I don't have the permission to engage on that compliance. I don't have the permission to kind of look for that. Even my question of, do you have a tendency to kind of listen to what people say to you? That was out of place. I should have been making sure that I have a patient first, that this person even wants to sit with me and be in that room. This person did not. They don't believe in psychology. They don't believe in psychotherapy. They wanted medication. It was a misreferral. The GP accidentally sent them to me thinking that I'm a psychiatrist when I'm not. And the person did not want to engage in the psychotherapeutic process. So there are so many cases like that where you have to check. I work right across from the parole office. Do you know how many people come to me and they don't want to see me? They don't want to know me. They don't want to sit in that room with me. There is clear defiance. And the only reason they're sitting in there is for me to tick the box to say to the parole officer, yes, they did some form of therapy. I can't do ISTDP, traditional ISTDP sort of vertical approach with those people where I just go for defenses and block defenses and go for emotions. It does not make sense. I have to talk to them more about providing them information about the potential benefits of psychotherapy, if they ever did want to engage in it, if they didn't just want to tick the box for their parole officer. Don't assume that every patient that comes to you knows what therapy is and that they know why they're there, and if they don't, that it's just because of a defense. That's just not the case. So I hope you enjoyed this video. I hope you go out there and you check more clearly and understanding in your patients that they actually know why they're there, they know what they want, and that there are none of these kind of lack of agreement on the task of therapy, or for that matter, the goal or the bond, really. Just make sure that it's all clear and it's all at least consciously understood and consciously grasped before you start going for the unconscious. I hope you enjoyed the video, and I'll see you again for the next video that's going to be about overemphasis. No, sorry. Yes, it's going to be about overemphasis. Sorry, my list is out of whack. It's going to be about assuming an internal problem. I hope you enjoyed this one, and I'll see you for the next one.